Thank you for having me this morning. It was an excellent talk from Dr. Wang and Dr. Newman. And so just to introduce myself, my name is Dr. Vince Ma, and I'm a medical oncologist here at the UW Carbone. And today I'm very pleased to be able to talk a little bit about some of the exciting clinical studies on actually improving outcomes of patients with advanced stage melanoma. These are my disclosures. And so as a medical oncologist, I primarily see patients in my clinic with advanced stage melanoma. And so the history for many of these patients are usually where they're diagnosed with melanoma, primarily a skin melanoma in the distant past. And unfortunately, despite excellent efforts by surveillance from dermatologists as well as surgery, we know that a proportion of these patients unfortunately go on to develop advanced stage disease or metastatic or stage 4 melanoma. And so oftentimes when I see patients in clinic with a new diagnosis of stage 4 or metastatic disease, I oftentimes like to give a very brief history lesson about this disease. Say if you were to see me back in the early 2000s, where at that time we really did not have much in terms of systemic treatment options. Really, the median overall survival was around 6 months. At that time, we really used things like chemotherapy and really has not been shown to be that efficacious for treatment of the disease. And so nowadays, if you look at what we have now, since 2011, we've had an explosion of different systemic therapy options now to really treat our patients with metastatic disease. Starting off with ipilimumab, also known as Yervoy. We have since then developed dual agent immunotherapy. We've also approved targeted therapy as well for patients who have a BRAF mutation. And then more recently, this past year, we got FDA approval of lifileucel, also known as TIL therapy, to treat patients with advanced stage melanoma. And so with this success that we've seen so far, what was thought to be unimaginable, a patient with stage 4 melanoma can literally have their disease nearly melt away. And we might even be thinking about, for some of these patients, we could potentially be curing some of them as well. What was recently published this past year was a 10-year follow-up data of patients who were treated with combination immunotherapy, specifically nivolumab plus ipilimumab, also known as Opdivo and Yervoy. And what they found was that the patients studied in this particular trial, after 10 years of follow-up, that we saw that about half of these patients were even alive. So such an unprecedented period of time that we're seeing now with patients who have this stage 4 or advanced disease. And with this success, we're also seeing a decrease in mortality over the past several years. Now, what I really wanted to emphasize here is that while we've seen a lot of great success with this treatment, we know that a good proportion of these patients that despite our excellent efforts to do things like surgery, radiation, and a variety of systemic treatment options, we know that a good proportion of these patients still unfortunately do not benefit or develop resistance to some of the treatments that I've mentioned as well. And so, as you can imagine, lots of very smart scientists out there are looking at just so many different pathways, different targets, different ways to help reinvigorate the immune system, lift the brakes off the immune system to better enhance the therapies for especially those patients who are resistant to some of the treatment options that we have available. And I know that with this illustration here, quite a lot being studied, but as you can imagine, lots of work still needs to be done, particularly in this space. One particular therapy that I really wanted to discuss today is actually about TIL therapy, or tumor-infiltrating lymphocyte therapy. It's also known as lifileucel, or the brand name is Amtagvi. As I mentioned earlier, this was FDA approved in February 2024. And this is a first-in-its-kind cellular therapy that was approved first in a solid cancer. And of course, it had to be melanoma. Now, cellular therapy has been investigated and it's been approved in other disease types, particularly lymphoma, but this is the first in a solid cancer. It is a type of cellular therapy treatment, and it is a single one-time treatment. And ideally, this particular therapy is used for patients who have previously received or progressed on immunotherapy or targeted therapy if the patients have a BRAF mutation of their tumor. This particular therapy is quite complex and is only available in select cancer centers. And we hope that by the end of this year, we'll have this treatment available here at the University of Wisconsin. So I'd like to walk through with you all just a little bit about how TIL therapy works, because this is a pretty novel therapy treatment, and it's not quite as simple as giving a drug that's an IV that you get through your vein or a treatment that you take by pill. So just to walk you through it a little bit, so you have a patient on the top left who has advanced stage melanoma, who has progressed on immunotherapy or targeted therapy. If there is a tumor that is large enough, that patient then undergoes surgery to remove one of those tumors. That tumor there, we're looking at specifically the TIL, or the tumor-infiltrating lymphocytes. These are essentially these white blood cells that are attacking or attempting to attack the melanoma tumor. And what you're hoping to do is that you want to expand upon that even further. You want to grow that in a lab. And so what you do is that you submit these TIL centrally to a company that then it grows it and expands it even further. And it takes several weeks for this to occur. Now, after that, it then gets shipped back to the institution that did the surgery, and you essentially bag it up and keep it frozen until you're ready to use it. Now, part 2 of this TIL therapy requires that the patient then has to undergo chemotherapy. And this chemotherapy is not intended to treat the melanoma itself, but to actually wipe out the immune system so you can accommodate the TIL therapy. Following the chemotherapy, the TIL is then infused into the patient, and subsequent to that, the patients then actually get hospitalized, where they're then getting a very potent type of immunotherapy treatment called high-dose interleukin-2. High-dose interleukin-2 is a type of treatment. It's an immunotherapy type of treatment, which essentially helps to expand the TIL even further within the body. And it causes a great deal of inflammation in the body. And so patients actually have to be hospitalized for monitoring as well as treatment of side effects. Sometimes patients actually have to be hospitalized, sometimes for several days, even for weeks as well. So let's talk a little bit about the success of TIL therapy, right? So this is what we call a waterfall plot. So what this is intended to illustrate is sort of the tumor shrinkage or the cancer shrinkage that we can see for patients getting a particular treatment. So if you see that horizontal line there, right at 0, that is the baseline. Each individual bar represents a patient who got TIL therapy in this particular trial. And what you want to see is you want to see that bar go below 0 because that represents tumor or cancer shrinkage. So you're looking for the best tumor shrinkage. And so what you can see here is that a majority of the patients actually had tumor shrinkage with TIL therapy. About 79% of patients in the trial had tumor shrinkage. And if you look at that 30% dotted line there, that sort of represents the most meaningful tumor reduction that we consider in oncology, a meaningful response. And we can see that about 31% of those patients had a meaningful 30% reduction in their tumor with this particular therapy. And so I have here some illustrations of how powerful and how great TIL therapy could work for some patients. And so if you see in the far left, a patient who, prior to having TIL, had disease in their skin. And about 3 weeks later after TIL, you can see some tumor shrinkage. And as far as 12 weeks after TIL therapy, you can see that almost an ongoing response to the particular treatment. What we've learned from the trials, particularly what was presented at ASCO this year, which is an international oncology conference, we know that for patients who achieve a meaningful response to TIL therapy, that they can have what we call durable benefit. And what that means is that they can have long-lasting disease control long after their TIL infusion. Now, some of the disadvantages or some of the cons associated with TIL therapy are some of the side effects. So as you can imagine, as we're giving patients things like chemotherapy, we can see things like low blood counts, low white blood cells, low red blood cells, low platelets, in which case they may need things like transfusions. Patients can also get fevers, chills, diarrhea, low blood pressure, and even risk of infection as they're getting the treatments such as chemo or the high-dose interleukin-2. We know that some patients can unfortunately die from this treatment as well because of the potent inflammation that you get from the high-dose interleukin 2, but also the chemotherapy that can also induce or cause infection. Now, we also know that TIL is not necessarily right for everyone. This is a relatively new therapy that's been in the making for the past 40 years, and there still needs to be some work done as well. But what we know for TIL is that it's ideal for patients, or for patients who are ideally fit enough to get this particular therapy. For patients who don't have a large enough tumor, they're unfortunately not eligible for TIL because you have to do surgical harvesting to isolate the TIL. Some patients, unfortunately, just don't have sufficient TIL quality in order to get this therapy. Other patients, for example, who are on active immunosuppression or those who have rapidly growing disease, unfortunately, are not great candidates. And as of right now, there are some studies looking into whether or not TIL can be done for patients who have ocular melanoma origins, so melanoma that originates in the back of the eye. As of right now, it's not FDA approved for that indication, but it is being studied. And we also are trying to look in whether or not TIL could potentially be something that we can offer to patients who have active cancer in the brain. And so as of right now, we can't do TIL therapy if there's active brain metastases that's progressing. So just to kind of highlight the schema, as you can imagine, there's very many avenues that we can sort of explore to make TIL therapy hopefully a lot easier for some patients and hopefully more accessible to more patients as well. And so in particular, there are several studies, as you can imagine, to see how we can make TIL therapy a lot easier and more accessible. One particular study called the AGNI-01 trial, which is a phase 1/2 study looking at the role of OBX115. This is another novel cellular therapy that's being investigated in a clinical trial right now. And so how is this a little bit different is that the TIL itself is actually engineered specifically to express a particular protein called membrane-bound interleukin 15. And so what's a little bit different is that when the TIL is extracted, these cells or these TILs are then engineered with a virus to help express those proteins. And what makes it very unique is that rather than subjecting the patients to high-dose interleukin 2 in order to expand the TIL in the body to work, you can see here that rather than using high-dose interleukin 2, we can use something called acetazolamide, which is far more well tolerated. By giving this particular medicine, you can actually help expand the TIL a lot easier. And how it does that is by actually activating the interleukin 15 that was engineered right into the actual TIL itself. And so what is some of the success we've seen so far in the earlier phases of the study? You can see here, for example, a patient who got this OBX115, and you can see some great tumor shrinkage as well. Now, one of the limitations, particularly for this study, is it's only studied in about 17 patients, at least what's been reported so far. And what we've seen is comparable numbers to what we've seen with the standard TIL therapy. So tumor shrinkage rate at about 73%, and greater than 30% tumor reduction in about 36% of the patients treated with this therapy. So a lot of great promise with this new cellular therapy option for the future. Another type of trial or study that's also being investigated as well is another type of cellular therapy treatment. So as I kind of mentioned earlier, right, with TIL, we oftentimes think about doing surgery. Well, there's an alternative approach to doing this as well. So one of the studies here in particular called the IMA 203 phase 1 study is looking at the role of a new cellular therapy treatment option called IMA 203 PRAME. And so this is designed to essentially help enhance cellular therapy that attacks a protein that is very prevalent in melanoma, in patients with melanoma tumors, which is called PRAME. And so in order to be eligible for this particular treatment, patients have to undergo a blood testing to see if they carry this immune signature called HLA-0201. And if they're positive, they could potentially be eligible for this potential treatment. Rather than undergoing surgery, the patients then have a procedure called leukapheresis, where we're extracting the immune cells from the patient, so not subjecting patients to surgery. And it takes far less time to grow these infiltrating lymphocytes or the cellular therapy in the lab. And so by the time the IMA 203 is manufactured, this can then be ready to be administered to the patients. Now, of course, for this particular therapy, patients still need to undergo chemotherapy to wipe out their immune system. But one of the nice advantages, particularly for this IMA 203 drug that is still being under investigation, is that we actually don't use very high doses of interleukin 2. So you have hopefully far fewer side effects and hopefully better tolerability for some patients. This is a waterfall plot, and as you can see here, fewer patients than what we saw with the TIL therapy, but a lot of promise from what we can tell so far. In terms of the tumor shrinkage, greater than 30%, we saw this in more than half the patients who got treated with this novel treatment. And as of right now, this study has entered a phase 3 setting and is available in select cancer centers throughout the United States. Shifting gears a little bit, I want to talk to you all a little bit about oncolytic virus therapy, which is a new type of therapy that has really entered the field of melanoma therapy over the last several years. Now, oncolytic virus therapy is not completely new. We actually have one that is currently FDA approved right now for advanced stage melanoma called T-VEC, or the brand name is IMA. This particular therapy is FDA approved back in 2015, and it is an oncolytic virus therapy. And so what this really refers to is that you're injecting an engineered virus that hopefully as you inject it in the tumor can help get the immune system to better attack and hopefully clear the tumor on the body. Now, as of right now, Imlygic or T-VEC is only appropriate for patients who have disease that is primarily confined to the skin or to the lymph node, for which surgery is not an ideal option. This particular therapy is only available in select cancer centers and is typically administered by surgeons and dermatologists. And here at the University of Wisconsin, this is an option that we can actually offer and is actually done and performed by Dr. Newman. So what is some of the success we've seen, for example, for T-VEC therapy? Well, you can see here an illustration of a patient who has a cutaneous or skin tumor of melanoma that was injected and treated with T-VEC. And you can see a lot of great success for this particular therapy. Now, as we kind of explore sort of newer generations of oncolytic virus therapy, there is one that has really entered sort of the space and probably a lot of like the marketing that we've seen so far, which is a drug called RP1, which is an engineered version of the herpes simplex virus. And so this new drug called RP1 has been studied in a clinical trial called the IGNITE trial, a phase 2/3 study, which is combined with a treatment called nivolumab, also known as Opdivo, already FDA approved. But by combining these two, this particular treatment was investigated in patients who have previously been treated with immunotherapy and targeted therapy. And one of the nice advantages of this particular treatment is that you can inject this not only in the skin, but also in tumors that are actually within or deep inside the body. So places like, for example, the liver. Similar to T-VEC, this is a treatment that can be given once every 2 weeks, only for a finite period of time while you continue the nivolumab. But as of right now, this treatment is not FDA approved. But some of the success we've seen, particularly for this particular treatment, is that if you look at this figure here, this patient on the top left who had an injection of the tumor directly into the forehead, we saw that it can actually induce an immune response and actually treat other tumors that are also not injected. And so you can see here that even by inducing or injecting one tumor in one area, you can see tumor shrinkage in areas like, for example, the liver or even the lymph nodes inside the chest. Some of the success we've seen so far, patients who have had greater than 30% reduction of the tumor, we saw that about a third of those patients had achieved that benefit. We also saw tumor shrinkage as well in non-injected tumors as well, in about 20% of patients treated with this particular therapy. I will also mention that there was a recent submission to get this treatment FDA approved last month, but unfortunately it was not granted. So what are some of the future studies that we're also thinking about, particularly for oncolytic virus therapy? As I mentioned, RP1 has been investigated, has been submitted for FDA approval, and there's ongoing right now meetings to kind of consider or reconsider getting that drug approved. But there are also newer generations of these oncolytic virus therapy. One in particular is called RP2. And RP2 right now is actually being investigated in combination with nivolumab or Opdivo. And in this particular case is being investigated in patients who have metastatic ocular melanoma. And is a particular trial that we actually have ongoing and opened here at the University of Wisconsin. So a lot of great excitement that we're seeing right now with oncolytic viruses, oncolytic virus therapies, and there's many more being investigated as well. Now, I know the purpose of my talk today was to talk a little bit about, treatment of advanced stage melanoma, but one of the best ways to treat advanced stage melanoma is to actually help prevent that from happening. And so no greater topic is there to talk about than to talk a little bit about cancer vaccine. So as you can imagine, vaccines have been well studied, particularly in the cancer space, for many, many years. And while we've seen a lot of success in getting the immune response to work, we have not seen much in terms of clinical benefit so far, until more recently, where we've really learned to understand that developing a vaccine that is not necessarily specific to tumor itself, but actually specific to the patient's unique particular tumor and their gene signature is probably what's going to be the most relevant in terms of inducing an immune response and helping patients to prevent melanoma from recurring. And so we're really entering the era of actually developing personalized medicine, going back into the patient's actual tumor itself, identifying the genes that are relevant, and developing an actual vaccine. And so this, as you can imagine, has the potential, particularly for patients who have been diagnosed with melanoma and had a successful surgery. How can we better prevent melanoma from coming back? A lot of publicity, particularly about the vaccine therapy, and more specifically, if you haven't seen it on the news, particularly the mRNA vaccine in melanoma. There's been a lot of talk and a lot of excitement about this new technology being developed in order to help melanoma from returning. This mRNA vaccine, which has kind of been renamed at this point as individualized neoantigen therapy, is a novel technique where we actually have to go back into the patient's originally excised or surgically removed tumor. You're identifying specific gene mutation signatures of the cancer itself, and you're identifying up to 34 specific genes. You then develop an actual mRNA vaccine based on that, and it's very individualized to the patient themselves, and you inject that as a vaccine for the patient. This has actually been first studied in melanoma, and a phase 2 comparison study was actually conducted in patients who had resected stage 3-4 melanoma and then received either pembrolizumab or Keytruda, which is a standard of care option after surgery to prevent melanoma recurrence, or they received pembrolizumab plus this individualized neoantigen therapy. And what they saw with this comparison was that the combined approach, combining immunotherapy with this vaccine, seemed to suggest that it may actually prevent recurrence than the standard immunotherapy treatment by itself. A lot of excitement with this, and as you can imagine, they moved this on to a phase 3 study, which actually just completed accrual this past year. And so by 2026 to 2027, we may be seeing some results of this. And if successful, this could be another treatment option for patients to actually help prevent recurrence of melanoma after successful surgery. Overall, key takeaways from my talk. As you can imagine, there's an unmet need for treatment options who have advanced stage melanoma, who have progressed on immunotherapy and targeted therapy. TIL therapy is currently FDA approved, but is only available for select patients who are fit enough and have great candidacy for this treatment. But there's ongoing novel clinical trials right now trying to enhance it and make it more accessible for patients. Oncolytic virus therapy has also entered the field again and is now being redeveloped in novel ways to become more accessible, particularly for patients who may not be candidates for TIL. And then patient-specific cancer vaccine therapy is also being studied right now to help prevent melanoma from returning after surgery. And I appreciate and thank you for your attention, and I believe we'll be moving on to the Q&A section next.